1, 2, 3. Hello, this is the Easy Orthodontics, hosted by two orthodontists. I'm Dr. Ji Dae-kyung from Orthodontic Barista Jr.
I'm Dr. Lee Jungkook from Orthodontic Barista Jr.
At Orthodontic Barista, we aim to provide informative yet relaxing orthodontic content for all our viewers, whether you're a general dentist or an orthodontic professional.
We hope you enjoy your lunch and have a relaxing cup of coffee while watching this program.
Our first broadcast was on February 22nd, 2022. This day is also marked the second anniversary of the opening of Dinal Broadcasting Station.
It's a memorable day with so many twos involved.
Let's make sure we don't get canceled and keep going strong.
We managed to squeeze in time in December to enroll in a barista course near Gangnam Station. And finally, we earned our barista certifications.
It's a European barista certification.
We really went through a lot to get it.
Did you get certified specifically for this program?
Yes, we worked really hard just to prepare for this.
And we have an announcement. If you have any questions during the broadcast, please leave them in the live chat, and we'll do our best to answer them.
Feel free to ask questions while watching, and you might even win a coffee coupon. It's a win-win-win. We look forward to your active participation.
So, how about a cup of coffee? While I can't pull an espresso, I'll serve you a hand-dripped coffee instead.
This feels a lot like orthodontic treatment. It requires a bit of patience. Hand dripping takes some effort, unlike a machine that produces coffee instantly.
As baristas, did you know which has more caffeine, drip coffee or espresso?
This wasn't in the script.
But drip coffee generally has more caffeine since it takes longer to brew. Anyway, we'll do our best to share not just our coffee knowledge, but also our orthodontic expertise with you. How about a cup of coffee? It's great to see you all. Starting today, we'll be sharing stories about orthodontics with you over the course of 10 episodes. Today's topic is orthodontics for implants and orthodontics without implants. In general, orthodontic treatment can be used to either close spaces or create new spaces for implant placement. That's the discussion we'll be having in this course. Shall we dive in?
Now, looking at the screen, you'll see a male patient in his mid-30s. Cases like this are quite common, right? In clinical practice, I still find myself debating over cases like this, and I'm sure many of you feel the same way. In this case, the second premolars in both the upper right and lower left jaws are missing. Assuming there are no other orthodontic issues, the biggest question is whether to close the space with orthodontic treatment or to create space for implants. What's your approach to making this decision?
Well, there are various factors to consider. I think the periodontal condition plays a significant role, as does the patient's preferences, which often weigh more heavily than expected. That makes these decisions quite challenging. From a clinical perspective, sometimes you might think the space is just too narrow and proceed, but after further examination with tools like panoramic x-rays, you might discover that the roots are too widely spaced apart. Situations like that can lead to unexpected complications. This is why it's crucial to reference multiple clinical data points.
I agree with your point, but we can't always accommodate every patient request. However, in this case, the patient clearly wanted to avoid implants as much as possible. So, we decided to proceed with orthodontic treatment instead. Looking at the missing areas, we can see that the upper right space is relatively wider, while the lower left space is narrower. One might think that closing the space in the lower left would be easier, given its size. But as you mentioned earlier, it's not just about looking at the crowns. We need to pay close attention to the roots. When the roots are widely spaced, the question becomes whether it's even possible to close the gap. For this patient, I explained it would take about 2 years and proceeded with orthodontic treatment. Here is a photo from the 11th month. Surprisingly, the upper molars in the wider space moved quite well, while in the lower jaw, we adjusted the bracket positioning. Specifically, we rotated the positioning counterclockwise for the 36th bracket. The treatment was successfully completed in 31 months. So, after 31 months, the root movement seemed to have gone well. This patient might seem like a fairly typical case, but after completing the treatment, he told me, "If I had known it would take this long, I would have just gotten an implant." Honestly, I felt this was a challenging case, but we managed well. But from the patient's perspective, the duration was unexpectedly long. I originally estimated around 2 years myself.
Moving molars in the posterior region is always challenging for orthodontists. The vertical eruption forces and other factors make it quite burdensome. In this case, considering the patient's orthodontic protrusion, perhaps extracting the 5th tooth and proceeding further might have been an option.
We'll show you 1 or 2 similar cases later. When there is protrusion, this approach can be incredibly useful. However, in this case, there were no other orthodontic issues to address, so we proceeded with closing the space.
Personally, I find that extracting the number 5 tooth makes retention particularly challenging. Gaps tend to reopen frequently. How did you handle retention in this case?
For me, when pulling the number 7 or number 8 teeth, the spaces in between usually maintain well. But when the number 5 tooth is missing, it's always a dilemma. For this patient, the treatment took about 31 months. It is quite a long time indeed. Typically, we attach a fixed retainer to the 6 anterior teeth in the maxilla. But in this case, I also added a buccal retainer to ensure long-term stability. We followed up with the patient for 4 years, and a recent X-ray showed that the relationship remains stable.
Fortunately, the 4-year follow-up data looks very promising.
Yes, I had the thought that if the space reopened, the patient might express significant frustration. After 31 months of orthodontic treatment, if gaps appeared, it would be a source of anxiety for us as well. Despite the potential risks, perhaps luck played a role, but it turned out to be a well-maintained case. Now, the next case is a scenario where we didn't close the space but rather widened it. This was another robust adult male patient. Looking at the 47th tooth, you can see that it's been treated with a root canal. So I am wondering if we can close the space in front of it with orthodontic treatment. What's your opinion on this? Given that this was a robust adult male patient with a root canal treated tooth, the bone density seemed extremely high. Considering the overall condition, I wondered whether we could even move the tooth effectively.
Additionally, it was mesially tilted, making the task of closing the space inherently challenging. Textbook explanations might suggest there is no issue with moving a root canal-treated tooth, but in practice, it often feels like these teeth are more resistant to movement.
In this case, there was spacing in the anterior region, so we attempted to close that spacing while moving the 7th tooth forward. However, it proved quite difficult. As a result, we used methods like an open coil spring to create space again and eventually proceeded with an implant. After the implant was placed, a new question arose. What should we do about the 38th tooth? Another dilemma arose. Initially, there was a plan for extraction, but since there was already an implant placed as a strong anchor in the anterior region, we decided to bring the 38th tooth forward as well. Ultimately, we opted to create space and proceed with the implant rather than taking too much time. However, bringing the wisdom tooth forward added to the treatment duration, thus requiring a significant amount of time. Whether expanding or closing spaces with orthodontics, the process always takes a significant amount of time. This is why it's always a challenging decision, and I always thoroughly inform patients about these aspects beforehand.
From a mechanical perspective, focusing solely on posterior protraction without involving the anterior teeth presents additional challenges, particularly in maintaining vertical control. It's not an easy task, even for orthodontists.
Mechanically, there are complexities we need to address, and I plan to discuss this in the next session.
Now, we're about to discuss a fascinating case.
It is a quite rare case. The main issue in this case is crowding. I always find myself wondering in these situations. Should we try to save and use the second tooth, or should we extract it? What do you think? What criteria do you typically use when approaching cases like this?
Since it involves the anterior region, aesthetics are the most critical factor. From that perspective, of course, achieving proper lingual root torque or labial torque, or even root torque in general, isn't easy. The question is whether opening spaces around the first and third teeth to align them would result in an aesthetically pleasing outcome. That's a separate issue altogether. Sometimes, we might extract the fourth tooth to make room. Or we might arrange the alignment with extraction.
When pulling out the second tooth, the difference in movement between the root and the crown always brings aesthetic concerns. To get straight to the conclusion for this case, the number 22 tooth had to be extracted. However, we extracted the 12th tooth instead and used it to replace the 22nd tooth. This case involved a procedure commonly referred to as autotransplantation. As you can see, we first created space for the 22nd position and extracted the tooth. The conditions for the transplantation were ideal, as the environment at the transplant site was symmetrical and the transplanted tooth had an identical shape. Given these factors, the prognosis didn't seem unfavorable. After placing the transplanted tooth, we fixed it in position for about a month. Since the initial positioning wasn't ideal, we applied orthodontic force to move the tooth to the desired location. The entire process took approximately 12 months to complete. Interestingly, this case saved a significant amount of time. When we look at the follow-up, we performed debonding 12 months after the transplantation. Follow-ups were conducted 1 month after debonding, as well as at 2 years and 4 years. Given the excellent transplantation environment, I believe the prognosis was better compared to other cases. It's quite fascinating to observe.
By the way, do you happen to have more cases of autotransplantation?
I have a few posterior cases, including extracting the 8th tooth for use in the 6th position, though they are relatively rare.
It would be great if we could make time to discuss such cases within our upcoming sessions.
If the program keeps expanding.
From a textbook perspective, the guideline is usually about 3 months for this type of procedure. When we looked into some studies, such as the 2004 AGODO paper and others published in Dental Traumatology, they mentioned that tooth transplantation followed by tooth movement was conducted after about 4 weeks. Dr. Zackerson suggested a waiting period of 3 to 6 months, while Dr. Poulsen, you're familiar with him, right, proposed 3 to 9 months. However, waiting as long as 9 months seems impractical for various reasons. Personally, I think the biggest concern would be ankylosis.
There are so many variables in cases like this.
In our case, how long did we wait before initiating movement?
I fixed the tooth for about a month, completed the root canal treatment beforehand, and then started carefully moving it after 1 month.
As we continue to discuss these cases, it's essentially a case presentation, or more precisely, a case study. We're incorporating some textual elements and literature reviews to provide you with a useful guide. I think up to about 3 months is reasonable, don't you?
Textbooks often suggest a waiting period of around 3 months, but I'm not sure. There are studies suggesting that 1 month is fine under certain conditions, and in my experience, I proceeded after 1 month. Perhaps I was just lucky, but it turned out well.
Earlier, you mentioned root canal treatment for posterior teeth. For transplanted teeth, root canal treatment is necessary. What's your opinion on the timing?
Since the apex was closed in this case, I proceeded with root canal treatment approximately 2 weeks after the transplantation. If you proceed too early, there's a risk of trauma or issues related to PDL. On the other hand, if you wait too long, there's a possibility of inflammatory resorption. That's why I believe around 2 weeks is the most appropriate timing.
In some ways, it's not about strictly following the textbook or completely dismissing it. Generally, we often talk about cases where the apex is about 2/3 or 3/4 opened. However, this patient is an adult, right? Personally, as an orthodontist, this was a case I found quite enviable.
It also reminded me of some similar cases I've experienced myself. Shall we grab a coffee before moving on?
Of course.
Coffee is always a good idea.
Let's go.
The next cases are more common scenarios. I'll show you 2 cases. Often, when we see missing areas, there's a tendency to immediately consider restorative approaches. However, especially for younger patients, it's important to first check whether there are any orthodontic issues. If there aren't, we can proceed with an implant plan. On the other hand, if there are orthodontic concerns like protrusion or crowding that require extraction-based treatments, it can be a bit disappointing when implants have already been placed in advance. Let me show you 2 such cases. The first case is one of the most common scenarios. In this case, the patient had missing teeth and also wanted to improve protrusion. We utilized the missing areas orthodontically and proceeded without placing additional implants. Instead, we extracted other teeth to address the issue.
There's likely no disagreement on this approach.
Now, for the next case, this patient also came seeking treatment for protrusion. However, there was already an implant placed in the premolar region, which is a common site for extraction. At the time of the implant placement, the patient might not have been fully aware of their protrusion issue. It's hard to say for sure, but as time passed, the patient realized I had protrusion and wanted orthodontic treatment. Upon examination, we found the implant in place, which, in such cases, would need to be removed to proceed with treatment. It seems like the sequence was reversed here. The implant was removed, and then the opposite side was extracted as well.
You didn't perform the removal yourself?
That's right. I referred the patient to an oral surgeon. In fact, just a few days ago, I encountered another patient who hesitated to proceed with protrusion correction due to an implant in the premolar region. I referred them to the oral surgeon, and they did an excellent job with the removal. Looking at these cases, I can't help but think that perhaps delaying the implant placement or addressing the issue through orthodontics first would have been a better approach.
Should we ask Osstem for help? Wouldn't a well-removable implant be amusing?
We will be looking at 4 more cases. The first case, labeled as Case 6, is fairly straightforward. As you can see, it involves multiple missing posterior teeth, a scenario you've likely encountered often in clinical practice. There's no single correct treatment plan for such cases. The plan should be tailored to the patient's needs and the practitioner's experience. What treatment plans do you usually consider for such cases?
Well, there are multiple missing teeth like this, and caries is severe. So, a straightforward approach might be to extract the 18th tooth, upright the 17th tooth, regain space, and then place an implant. But we also need to address the patient's feelings and concerns. Many patients experience a significant sense of loss when they're missing teeth, not to mention the financial burden of implants.
That's why it's not always feasible to proceed with orthodontics just because a tooth is missing. In this case, there were also issues related to the anterior teeth, so we decided to close all the spaces orthodontically. This is how the spaces were closed. Let me just proceed and show you the case without details. Regarding the specifics of the orthodontic diagnosis, we'll discuss them when we have another opportunity. For today, it's about showing that this type of treatment is possible. This case took approximately 30 months to complete. Retention is always crucial for us, isn't it? We need to ensure the results are maintained even after the treatment is finished. For this patient, we conducted a 5-year follow-up. Compared to cases where the missing 5th tooth is restored, cases like pulling the 7th or 8th tooth seem to have better retention, at least in my personal experience. This case showed no major issues even after 5 years. This case involves several challenges. What treatment plans could we consider for this situation?
That's the question, isn't it?
I don't think there's a definitive answer.
But let's see. It's the 47th tooth we're talking about, right?
The issue seems to involve the first quadrant and fourth quadrant teeth.
One possible approach might be to extract the most posterior molar, upright the adjacent tooth, and then place an implant. For the 10th site, placing an implant to serve as a counterpart for the 6th tooth could work, while saving the 7th tooth. For the remaining areas, how about regaining space and proceeding with implants?
Yes, exactly. I found this case to be quite a dilemma as well. This was a young female patient in her mid-20s. We always aim to reduce the number of implants whenever possible, and we decided to try saving as much as we could in her case. For the 47th tooth, essentially the 46th and 47th positions, we worked on uprighting and intruding the teeth over a period of approximately 24 months.
We see that there is no clearance in the 47th region.
I will admit that I might have been lucky that this case turned out so well. Extruded teeth, like in this case, require a great deal of intrusion and careful mechanical planning. Still, we managed to utilize the existing teeth without extractions. If we look briefly at the mechanics, we could have closed some of the space in front of the 6th tooth with more effort. But we decided to proceed with an implant plan instead. Using a mechanism where the 6th crown was moved backward and the root was pulled forward, we achieved uprighting. Regarding the 7th tooth, we performed intrusion by placing screws only on the buccal side. Ideally, including the lingual side would result in a more balanced intrusion.
However, I've never attempted placing screws on the lingual side before.
There was one case where it was possible, but the patient's discomfort and the technical challenges made it too burdensome. In this particular case, the tooth was slightly tilted lingually, which allowed us to proceed solely with buccal side intrusion. Fortunately, the treatment was completed successfully.
In any case, the treatment proceeded almost textbook-like. As the 47th tooth underwent intrusion, the alveolar bone descended along with the uprighting of the 46th tooth, and the alveolar bone distraction occurs. While this case was successful, there might be considerations for other cases where buccal version could be an issue. In this instance, there were no opposing teeth. Do you have any tips for addressing such situations?
To be honest, if the tooth had tipped further buccally, I was prepared to also place screws on the lingual side. However, since there wasn't much additional tipping, fortunately, the treatment progressed smoothly.
What kind of wire did you use for leveling at the end?
We typically use TMA and SS wires. For the 47th tooth, it was highly rotated, as seen from the occlusal view. Initially, we focused on nickel titanium wires due to the significant rotation. Later, to address torque, we utilized TMA and SS wires as well.
This might be a story from the old days, but from my experience based on 26 years of experience, I sometimes wonder what it would have been like to use loops to apply buccal torque just to the crown, or even to add lingual torque.
You're talking about the classic back-in-my-day approach, right? Exactly. Back in my day, I primarily relied on screws since I'm from the screw generation. It would be great if you could share more of your insights and teachings on these methods.
Create the opportunity to do so.
Now, let's move on to the final case. It is not just a fun case. It's certainly not a typical one and is quite interesting. It seems the patient was advised to undergo extractions, particularly in the third quadrant. Of course, uprighting one tooth and extracting another, with perhaps one implant needed, would likely be required. In this case, the patient also needed some orthodontic treatment for the anterior teeth. So we decided to focus on preserving teeth as much as possible through orthodontic treatment. The 38th tooth in this case was significantly tilted lingually. It was quite tilted, wasn't it?
Extraction could have been a reasonable option as well.
Extracting the 38th tooth and uprighting the 37th might have been feasible. But the patient strongly preferred to avoid implants. While we don't simply follow a patient's wishes, I wanted to give it a try and see if we could manage by pulling it into position. To show you the process, we first pulled the 7th tooth, and it was successfully brought into position. My main concern was whether there would be significant resorption of the alveolar bone level. But thankfully, the 7th tooth was upright without any such issues.
The treatment proceeded smoothly, almost like a textbook case.
I'm not sure, but I'd say the results turned out quite well in this case. If you look at the clinical photos, you'll notice that while it's easier to apply various mechanics in the anterior region, the posterior region is so far back that it becomes extremely challenging to do much. We managed to pull the 7th tooth, but the 8th tooth was rotated 90 degrees. While we succeeded in uprighting it, we couldn't fully correct the rotation. Instead, we positioned it to a point where it posed no issues in occlusion. This patient's treatment took approximately 29 months. While it wasn't an extremely lengthy process, the patient has been followed up for about 3 years. Thankfully, the teeth in the third quadrant are being used very well.
We've seen some remarkable cases today.
I must admit, the results are quite astonishing.
I've been holding back from saying this carefully, but here we are, giving a lecture at an implant company, and it seems like we've focused heavily on orthodontic pulling, hasn't it?
Of course, implants are important too. But in discussing these cases, we ended up showcasing cases without implants.
I sincerely hope this won't be our first and last broadcast.
It's not about avoiding implants being less beneficial for the patient. It's about finding ways to reduce the need for implants where possible.
Are you feeling nervous?
Next time, we'll come prepared with cases that showcase successful integration of orthodontics and implants. I've given you a general overview, and I'll share one failure case during orthodontic pulling. I'll briefly introduce this case without going into the details of the diagnosis. The patient came in seeking treatment for crowding, and we decided to close the spaces in the 30s and 40s region. In the third quadrant, the 36th tooth was extracted. The plan was to pull the 37th tooth forward to achieve the desired occlusion. This is the initial panoramic image. Please pay close attention to the 37th tooth. After extraction, we began pulling the 37th tooth forward. However, during the first couple of months of pulling, significant mobility was observed in the 37th tooth. At that point, I realized the tooth cannot be preserved. Ultimately, during the process of pulling after the extraction, I realized the tooth couldn't be saved. While monitoring the situation, I noticed that the initial panoramic image revealed some periodontal issues related to the 36th tooth. The defects didn't significantly improve during the pulling process. Given these circumstances, I think it would have been challenging to manage successfully.
This is a common blind spot with panoramic images. It was quite difficult to identify at the time.
I was a bit unsure, but I expected that with a CT scan, things might get better. I even had slight hopes of seeing some bone formation during the process, but that didn't seem to be the case.
Ultimately, if the periodontal disease is under control, it might be manageable. However, in this case, it could have been an active cyst.
The conclusion is that pulling isn't always an option. and we certainly can't rely solely on panoramic images to assess the condition of the bone or other factors. These aspects require further evaluation. As for the mechanics of pulling, we'll discuss that in more detail in a future session.
In such cases, an implant would be necessary.
Yes, that's correct.
This was our first broadcast, and we went through 8 or 9 cases today. How was it for you?
Originally, I had prepared about 20 cases, but I had to cut them down significantly. While I would have loved to share more, I also wanted to keep it engaging and not overly time-consuming. I hope you found it worthwhile.
I trust that the invaluable cases shared by Dr. Lee Jungkook will not only resonate in your hearts, but also enhance your skills in the clinic. Thank you for joining us today, and I hope you have a wonderful time with your afternoon patients. In 2 weeks, our topic will be orthodontics that utilize wisdom teeth. This time, we'll explore cases where the focus is on preserving and utilizing wisdom teeth, rather than expanding space.
These cases were approached with the idea of avoiding implants entirely, which made them quite nerve-wracking. I might need to consult with the company to see if this approach is feasible.
See you next time.
And thank you.